This is a investigator-initiated single institution phase 2 study that was designed to look at the efficacy and safety of giving this drug called Cevostamab in patients who are getting a commercial BCMA-directed CAR T-cell product. And the patients all had relapsed refractory multiple myeloma. Cevostamab is a FcRH5 targeted T-cell engaging bispecific antibody. So FcRH5 is a antigen expressed highly on myeloma cells, and its expression is independent of BCMA expression. So it's another target to go after for T-cell directed therapies. And Cevostamab previously in a phase 1 study as a single agent shown activity in highly refractory myeloma patients, including those who had had previous BCMA therapy. So we hypothesized that perhaps giving Cevostamab after BCMA CAR T-cell therapy might be a way to sequentially target 2 different antigens on the myeloma cells and perhaps prevent or at least delay relapse in patients getting BCMA CAR T-cells. Because we know that while BCMA CAR T-cells are very effective, the vast majority of patients unfortunately do relapse, and antigen loss or downregulation may be one mechanism of escape. We ended up enrolling 27 patients in the study, and what I'm presenting at the meeting is really just a preliminary or unplanned interim analysis. So the accrual is complete, but the follow-up is still ongoing, and many patients are still on treatment. And what we've seen so far is that the Cevostamab treatment post CAR T cells does appear feasible. We are planned to give a total of 8 cycles of Cevostamab to the patients. And then if they were MRD negative complete response, we stopped. If they still had any detectable MRD or not in the CR, they got another 8 cycles. And we found that the median number of cycles given was 8, which means we were able to get the treatment into the majority of patients. And in terms of toxicities, we did see sort of expected hematologic toxicities, including reversible grade 3/4 neutropenia in about 44% of patients, grade 3/4 thrombocytopenia in about 20% of patients. But cytokine release syndrome, fortunately, was fairly uncommon, only 15% of patients, and all grade 1 and grade 2. We have not yet seen any ICANS or HLH. And the other non-hematologic toxicities, for the most part, were expected and all low grade. We did see infections in about half the patients, and about 15% were grade 3/4. So we do think this is feasible to give this treatment. That was one of the questions, how patients would tolerate this. In terms of the main efficacy analyses, so what we're seeing so far is that patients had to have at least stable disease or better after CAR T cells to get on the study. And about 60% of the patients were in a CR already coming into the study, which is about 10 to 12 weeks post CAR T cells. And so far, at least in the evaluable patients at 1 year post CAR T cells, 93% now are in complete response. And all of those patients are MRD negative at 10 to the -5th, and close to 80% have a MRD negative CR at a 10 to the -6 level. So we are seeing that we're able to sustain MRD negativity in the vast majority of patients who are enrolling so far. And with a relatively short median follow-up, only about 12 months, over 90% of patients are still alive and progression-free. In fact, we've only had 1 progressor so far at the time of the data cutoff, which was late June. We know from multiple studies that MRD negativity certainly has prognostic value, and I think what we're learning is it's more important even than just a single MRD negative time point is this concept of sustained MRD negativity, and particularly after CAR T cells. That an early MRD negativity at 1 month or 3 month post CARs may not be quite as predictive as patients who are able to sustain that MRD, particularly for at least a year after the CAR T cells. At least in some of the early studies in late line myeloma, that seems to be predictive of those patients who might go on to have that really long PFS. So that's the reason why we chose a 12-month MRD negative CR as our primary endpoint, hoping that if we could increase the proportion of patients who sustain that MRD for a whole year, that this would translate into better PFS down the road, and perhaps even a cure fraction of patients. So that's highly speculative at this point. So as with almost all bispecifics in myeloma and other diseases as well, we've learned that if you just start with the full dose right away, particularly in patients who have a lot of active disease, you get very high rates of cytokine release syndrome and other toxicities. And so if you step up, meaning start at a low dose and then maybe go to a medium dose and then eventually get to the full dose, you can mitigate that CRS and it can be much more manageable. And so step-up dosing was studied for Cevostamab in the original phase 1 study in heavily pretreated relapsed refractory patients. And in that setting, they used multiple step-up doses, and ultimately that led to a sort of more acceptable risk of cytokine release syndrome. In our study, because patients are really going into the trial with well-controlled disease, because they're obviously getting enrolled post-CAR T cells and the tumor burden is low, we felt we could just go with a single step-up dose. And so we gave one dose of 3.6 milligrams IV, and then a week later, patients came back and would get the full dose of Cevostamab, which we determined in this study that the optimal dose was 132 milligrams IV. And then starting cycle 2, they just stayed at the 132 milligram target dose every 3 weeks thereafter. And they were hospitalized for 48 hours after the first step-up dose and the first full dose. But after that, then they could get the rest of the doses as an outpatient. And we found with this strategy that it really did seem to minimize the risk of CRS. As I mentioned, only 4 patients, or 15%, had CRS in this study. All of it was grade 1 and grade 2 and very easily managed. I think the first step is just to continue treating all of the enrolled patients, try to get them through the 8 cycles of Cevostamab and look at the primary efficacy and safety endpoints. And so that's going to be I think the main priority, looking at the primary endpoint. But then we are doing a lot of biobanking with plans for correlative analyses. And so some of those are just starting to get underway. We have some interesting questions looking at what's the impact of Cevostamab on the CAR T cell population? And are we re-expanding any of the CAR T cells that might still be present at the time the Cevostamab is started? And do we enhance their persistence in any way? How are we impacting the sort of differentiation and phenotype of both the CAR positive and CAR negative T cells in the patients? And what's the impact on, for instance, T cell exhaustion and other sort of markers of T cell function long term? We're collecting serum on all the patients, and we're going to be monitoring soluble BCMA levels and soluble FcRH5 levels to see if that could be a potential predictor of response or resistance. And then we finally have serial bone marrow analyses. For these patients, we're collecting bone marrow mononuclear cells pre-CAR, pre-Cevostamab, and then post-Cevostamab at various time points. And we're hoping to really do a deeper interrogation of the immune microenvironment. And I think that those will be more informative once we have much longer follow-up and we have a sense of which group of patients are going to be our long responders and which patients perhaps have shorter responses, and then try to see if we can tease out any predictors of that.